Hello, everyone, and welcome to the Pop That Mumma Podcast. In this episode, we have the incredible Dr. Melanie Jackson, and we're going to be talking all about vaginal examinations. If you don't already know, vaginal examinations are a routine intervention, so you will be offered VEs some point in your pregnancy and labour and birth. And so this episode is going to give you all of the information you need to make an informed decision about whether you accept these interventions or not. This is going to be a great episode. I definitely got a bit of a girl crush on Melanie right now because she is doing the most. So as always, get yourself a cup of tea, get yourself comfortable and enjoy. Hello, Melanie. So lovely to have you back. How are you? Tell us a bit about how you're doing, but also who are you for those of you who have not come across your work?
Yes, thank you, Poppy. So I'm Melanie Jackson. I'm here in Australia. I'm a midwife, but I have also got my PhD in midwifery, and I've been doing midwifery for 18 years. Most of my work is done in home birth, but I also train and mentor other private midwives here in Australia. The Great Birth Rebellion podcast, that is a big part of my day and of my week, is generating those podcast episodes. And I run the Convergence of Rebellious Midwives conference every year here in Australia. I mean, everybody's welcome. I'm a mum of 2 as well. What else do I do? So many things. I crochet. I'm learning dojo this year. That's me in a nutshell.
You are busy, girl. You're very busy. Yeah, so to email you and I'm like, she's got too many emails. How do I get this woman down? I have to now on a podcast to talk me dead. That's literally the only way these days. So yes, guys, I will link her fabulous podcast in the show notes because you must go over there, subscribe and listen. I personally thoroughly enjoy it, even though I know most of the things you're saying. It's just amazing with all of the research as well that you present, and everything is evidence-based.
One of the biggest purchases you're going to make in pregnancy is a buggy. It can feel really overwhelming with all of the choices out there. I've been there as a first-time mum being like, which buggy should I actually choose? That's where Bugaboo comes in. Parents around the world are obsessed with their innovative, family-friendly products. And you know what, guys? So am I. I'm actually really excited to have Bugaboo as our sponsor because I am the biggest Bugaboo fan ever. Like, I literally recommend them to everyone who will listen. Everything is designed to be long-lasting, comfortable, and easy to use. I went with Bugaboo with both of my girls, and honestly, it was the best decision. If you didn't know already, I'm going to be needing a double buggy soon. I couldn't be more excited about having another little one. And luckily, I'm not going to have to stress about what pushchair to get because I know what I'm getting, the Bugaboo Donkey 5. It's the incredible buggy for growing families, or if you just need extra storage. So the brilliant thing about it is it switches from a single to a double so easily with just a few clicks. And I love that the little ones are next to each other because they can see each other and actually experience the world together. So cute. Even though it's a double buggy, it's still really easy to steer and compact, fitting through a standard doorway or a lift. So now that the buggy's sorted, I'm going to be focusing all of my time on birth prep and enjoying these last few months as a family of 4. If you're in the market for a pushchair, use the link in the show notes or visit the Bugaboo website to find out more. Their whole range is designed with parents and growing families in mind.
So we're talking about VEs, and the first question really is for someone who has no idea what a VE is. What is it? What is the midwife or doctor doing? Why? And what do people need to know about?
Yeah. So vaginal examination. Essentially, they'll put 2 gloved fingers into your vagina. And what they're looking for is your cervix, which is the part of your uterus that opens. If you imagine your uterus being a balloon, the very end that's all tied together, that's your cervix. And during labor, that opens wide enough for the baby to come out and gets integrated into your uterus. So your care provider is very interested in understanding how dilated your cervix is, how short it is, how long it is it soft? Is it firm? Is the baby's head well applied to it? Is the baby's head really hard down on it? Or is the baby floating up and away from your cervix? We're also interested when they do vaginal examinations in the position of the baby. So we can tell by feeling the bones on top of the baby's head, we can get a visual sense of which way your baby is facing. Is it facing backwards, frontwards, whichever way? Is it tilted to the side, or is it very well straightened down in your pelvis?
Can I ask, in terms of the hierarchy of the importance of the information that they're trying to get, do you think that the position of the baby's head is the most important if you imagine what might change the course of the labour? Or is it dilation? Like, what is the kind of most important thing?
I don't think we can rank them. I know when we go to do a vaginal examination, you're aware that this is a really invasive tool. It's a really invasive diagnostic tool. The woman is lying down, probably quite uncomfortable because she's also labouring. Although vaginal examinations are increasingly being done through pregnancy, that's a whole different thing. But in labour, they're often uncomfortable. We acknowledge that. We acknowledge that women actually don't like vaginal exams. The research shows women would very much prefer not to have them if they didn't need to have them. So when we do them, we very much try to get as much information as we possibly can. Now, for me as a home birth midwife, I very rarely do vaginal exams unless I think they're absolutely clinically necessary. And so I might do one, for example, because I think, I think this baby is malpositioned. In which case, for me, the importance of doing the vaginal examination is I would like to know the position of the baby. And for me, that's the most important piece of information that I'm after for this vaginal examination. But I will also check, but how dilated is she? And is something else going on? We try not to assume what we're going to discover in there. Just kind of clear your mind and go, what are you actually feeling? What's happening in there? This gives us diagnostic information.
Why do we need to know how far dilated a woman is in labour?
Yes, it depends on who you ask. So if you ask me, I don't think we need to know how dilated you are in labour. I think your cervix is dynamic, that every woman's cervix shortens, opens, and behaves differently in labour. Each labour is unique, each cervix is unique, and so much affects it. I think the cervical dilation is a minor issue to labour. However, if you're giving birth in a big institution within a maternity care system that has to be standardised, then your clinician wants to give you a vaginal exam every 4 hours, and they expect your cervical dilation to progress in a particular way. So if they do a vaginal examination and then 4 hours later they do another one, they're going to expect your cervix to have shortened, softened, and opened further than the previous vaginal examination. And they use this as a way to diagnose labour progress. But there are so many things that indicate labour progress that are independent of how dilated your cervix is. Because you could be 10 centimetres dilated, you could be fully dilated, but still no closer to giving birth because potentially there's another issue. Maybe the baby's malpositioned. Maybe there's a proportion issue. Maybe you haven't got contractions. I know that happened to me. I was fully dilated, but my contractions stopped. It was a very long labour. For some reason, I wasn't getting contractions. So the dilation was irrelevant. I wasn't getting contractions. I needed those. And so they are curious about your cervical dilation because to mainstream maternity care, that is an indication of maybe how close you are to giving birth. But the truth of it is that a cervical examination can tell you what your cervix is doing and where your baby is in that moment, but it's not predictive. It can't predict now if you're 5 centimetres that you're going to have your baby in 5 hours or 2 hours or 10 hours. We don't know. It's a tool that mainstream maternity care system will use, but it doesn't really match with the research, so, which I'm sure we will get into.
What happens if a mum is labouring and let's say now they are not dilating past 4 or 5 centimetres and it's been hours and hours and hours? What's then kind of on offer?
Okay.
Or what would be recommended?
Sure. Yeah. If you have a home birth midwife who is willing to wait, you'll be offered a rest, a lie down maybe, soak in the bath if you need to kind of take some breaths out and just relax a little bit. If you're in hospital and they check and you're 4 or 5 centimeters, and then they check in another 4 hours and you're 4 or 5 centimeters, you might be diagnosed with what they would call failure to progress or labor dystocia. The seeming lack of progress will set off alarm bells in your clinician's mind. But your baby might have been doing a lot of work. You might have been getting contractions and your baby was repositioning itself or moving down further into your pelvis, even if your cervix isn't opening. So there's been progress and change, which is amazing because all of those things need to happen for you to have a baby. But we're very fixated. We're very cervix-centric. We're very fixated on what the cervix is doing, less interested in all of the other amazing progress in labor. And hospitals are very pressed for time. They want you to move along in your labor process. You might be offered something to speed things up, like what we call an augmentation, where you would get IV artificial oxytocin. Some places it's called syntocinon, some places it's called pitocin. Same medication though. And the idea is that this would give you more contractions and ideally create more cervical dilation. So if your labor is slow or you're not progressing, one of the strategies might be to offer artificial oxytocin. Or if you've got midwifery care with a midwife who is willing to accept slower progress, and you and your baby are well and fine, not doing something is okay. Unless, obviously you or your baby are having a health issue and time is of the essence. It's okay to wait as well.
And if someone's listening and they experience this where they're not dilating past a certain point, what are the kind of main reasons why labor dystocia happens, and what are the kind of more natural methods for helping yourself to progress? At what point should you be concerned and where you might want to accept, the synthetic oxytocin?
Sure. Well, firstly, the very real possibility is that nothing's wrong and that this is just how your labor is going to be. And there's some great research. We used to believe that your cervix should dilate in a linear fashion. So if you looked at a chart, it would go from the bottom of the chart and there'd be this beautiful straight line which traveled all the way to the top of the chart to 10 centimeters. But now we know there are these natural physiological plateaus through labor dilation. One of those is between 4 and 6 centimeters. There's a natural labor plateau. And the reason why I said that number, because I've been with a heck of a lot of clients where it's that number again. Yeah, exactly. And I did have a look at the research before starting this podcast because I speak about vaginal examinations, and there's a natural plateau around this state between the 4 and 6 centimeters, and it can actually naturally go for hours. 5-6 hours is considered in this new research as normal. So what they did is they measured the cervical dilation of women in labor of only pregnancies and births that ended in the baby being well. So what the idea of this research is if the baby's well, then whatever happened before that was okay in labor, physiological labor, because the outcome was a well baby. And what they determined is there could and very well may not be any danger to having a prolonged pause of cervical dilation in that 4 to 6 centimeter stage and still have a very well baby. And so this newer research indicated that actually these plateaus are completely normal and fine. So one thing you could do is wait for the plateau to pass and just make sure that your basic needs in labor are being met. And your basic needs are to feel safe, private, unobserved, your temperature to be, comfortable, adequate hydration, being cared for without being interrupted, being allowed to sleep, being supported through your contractions by somebody that you feel, a place where you feel comfortable. That's going to facilitate the best physiological flow for your body. So you could wait it out in an ideal environment. Some women don't feel comfortable with that. They want to move it along, especially if you're in a more hostile scenario where your clinicians are also really encouraging you to accept things to move along. So it really depends on what you want to do. If your baby is well and you are well, ask yourself, why would I speed this up? what's the problem.
Really good tip.
For all my London and city mums, I know just how important it is to find a buggy that actually fits your lifestyle. Something that you can get on the bus or squeeze onto the tube without stressing. And that's exactly why I am obsessed with the Bugaboo Dragonfly. It can fold down with one hand while using both the carry cot and seat, so no need to remove them. This is so helpful when you're holding the baby or juggling a bag, which you so often are, right? It is such a game changer if space is tight or you're always on the go and don't want to compromise on comfort. If you're looking for the perfect city pushchair, definitely check out the show notes or the Bugaboo website for more on the Bugaboo Dragonfly and the full range of incredible products made to move with you and your little one.
I think, is it in the US? I think one of the leading causes of cesarean is failure to progress.
It's a very, very common reason that people will put down as failure to progress.
And you see women say, I just wasn't dilating. My cervix couldn't dilate.
Well, I think the expectations on cervixes are too high. So the
these supply Olympics, they're like, what? They don't even know all these rules have been made.
I know. So what's happening is there's been this weird rule set, this unusual standard, this unphysiological standard has been set. And then any cervix that doesn't perform to this unrealistic set standard, then it's labelled failure to progress. You're a failed cervix. And so we need to help you. You failed. Now it's time for an augmentation with some medication or a cesarean section because the performance doesn't meet the expectation. But that doesn't mean that something's wrong. It just means that this arbitrary, bizarre expectation of progress hasn't been met. The reality of the research around vaginal examinations is that they've shown quite clearly that routine vaginal examinations don't improve outcomes for labour and birth. Whether you do them or not, there's no improvement in the outcome. And clinically, I can speak to that in a sense that as a home birth midwife, I don't do routine examinations at all. The only time I use them is when they're clinically indicated. So if I think, okay, there's a medical issue going on here, we would have some valuable information by doing a vaginal examination. Or of course, if the woman asked me, then sure, there's a great reasons to do vaginal examinations. But the research is not behind routine vaginal examinations.
Yeah, I'm not surprised, to be honest. Here in the UK, certainly, when you arrive at the hospital, the expectation is that you will accept a vaginal assessment to be admitted because you have to be in active labour. So what are your thoughts on that? Like, as I understand, it's our legal right to say no because it's our bodies. So what happens if a woman wants to say no in that scenario?
So you have a right to say no. And as you said, vaginal examinations are a triage tool for who can be admitted to hospital and who can't be admitted to hospital. And that's beside the need of the woman. So this is the issue here, isn't it? Is that women are only admitted into getting maternity care when their cervix is performing to the expected standard. It's irrelevant if the woman feels like she needs maternity care or she needs support. That doesn't factor in to the triage situation. Maybe it will in units that are less hard-pressed for time or have room and space for that. And that maybe you're lucky and you come and the midwife is like, oh, wow, you really need maternity care. It actually doesn't matter what your cervix is doing. Again, and there's a lot of research on this early experience of women who are turned away from hospital because their cervix is not performing. Women come to the hospital, they engage with the service because they want maternity care, only to be told that you don't qualify for maternity care yet. You don't qualify for labour and birth care yet because your cervix has not reached the designated dilation. It's absolute insanity. So you could say, look, I'm declining a vaginal examination. What I actually want is support, love, and maternity care, regardless of how dilated my cervix is. So it's just a triage tool. It's not clinical need.
Will you easily be admitted without one?
They can't turn you away. And you have a right to decline. But this is where there'll be a bit of argy-bargy battling to go on, which is unfair. by the way. I'm not saying this is not right. It's really unreasonable. And if you ask the hospitals or the services, they'll say, well, we actually don't have the capacity or the staff or the room or the time or money to care for everybody. There has to be some kind of criteria for who gets access to the labour and birth unit, which is really unfortunate. I totally understand it. It's a service with limited resources. But if women are going there, they want care. And so their early labour experience is really impacted negatively because of that.
So what are the kind of benefits and risks then of VEs?
The benefit can be that you discover some great information that gives you hope. And you think, oh, great. Okay, I want to do a vaginal examination because I think I'm getting close. And the midwife says, oh my gosh, you really are. You're so close. Go for it. Have your baby. That could be good information. We can also get interesting and helpful information about the position of your baby. So if you've been working on something, for example, I had a client with posterior position baby. We did all kinds of things. And then when we rechecked all of the things, I was like, great, amazing. Your baby's rotated. It's moving down into your pelvis. I believe we've solved the problem. This is amazing. So there can be helpful diagnostic tools. The risk could be that you get disappointing information. So you might think, oh, I really thought I was a lot further, and now I'm feeling disheartened because I'm only, in inverted commas, only 4 centimeters, or, if you're not as far along as you used to be. The other physical risks, the more vaginal examinations you have, the more risk of an infection for yourself as the woman in your uterus. So some facilities have a policy, at least here in Australia, I'm not sure what it's like there, but if you have more than 5 vaginal examinations, they will give you prophylactic antibiotics because they acknowledge that every single vaginal examination you have increases the risk of an infection in your uterus. The other risk is that they could accidentally break your waters if you didn't want them to be broken. They're incredibly uncomfortable. Also, be very aware as a clinician that there's a large proportion of women who've not been treated well in their lives and who have a history of abuse. And vaginal examinations are an incredibly triggering experience because it's an authoritative figure. Women might not actually want it but feel like they have to. They may have been coerced into that. There's an opportunity here for things to come back to the woman. So she might get flashbacks and have quite a trauma response. So there can be a very big emotional impact of vaginal examinations during labour, especially if the woman is not feeling like she's fully consented to that and has been coerced into it. So I think that is...
Just to jump in, sometimes, the woman, if they have had previous sexual trauma, they may not even realise that this VE is going to cause that response. Whereas obviously you do have some women who will think about that ahead of time. I've worked with my doula clients who have said, look, this is the one thing I'm worried about. And we've communicated it with the healthcare team, and they've actually said, look, we won't do it unless we really think that you need to ahead of time. A lot of women may not realise that this could be a real trigger.
Well, and that's the thing. If the woman agrees to it and wants it and is accepting of it and understands it, then the possibility that they'll be upset by it is a lot less. So, but it's the routine vaginal examinations that where women feel pressured to have them that can really trigger this response. And even to the degree, I've had clients who had not realised they'd been abused in their life. And then when they were in that scenario, these visions came back. And so it's a very powerful and invasive diagnostic tool in so many ways, both positive and negative. But I think that a lot of clinicians are desensitized to the experience of a vaginal examination because midwives and doctors are trained to normalize. So normalized. Every woman, every 4 hours. That's the general trend. And so if a woman is there for 16 hours, she could very well get at least 4 vaginal examinations. And if the midwife is caring for multiple women, the amount of times that they do it each day, it makes them, it feels just like a regular day. But it's a big deal for women. And so, the downplaying of vaginal examinations, I think, is a real shame. We have to consent to these things or they won't be done to us. So women need to know that if you don't want them, it is absolutely okay. But then that could make your clinician uncomfortable because they just think, I don't know, I actually don't know how to care for a woman without knowing how dilated their cervix is, which is insane. But it's the reality.
I might be a city girl, but I also love escaping into nature and exploring with my gorgeous family. Fresh air and little adventures mean so much to me, and it's really important that my girls get to grow up with those experiences too. That's why it makes such a difference having a buggy that can keep up. The Bugaboo Fox 5 Renew is built for all terrains and is super comfy for baby, so you're not going to need to stress about every bump in the road. Plus, it's really easy to steer. Honestly, it's a buggy you can take anywhere, from city pavements to country walks, and it's now available in forest green with matching accessories. Guys, I am so obsessed. It is gorgeous. So, for naptime strolls, city commutes, or weekend adventures, Bugaboo has a pushchair designed to fit your life. Use the link in the show notes or head over to their website to find out more about the Bugaboo Fox 5 Renew and their whole range of incredible products. Thank you so much for tuning into the Pop That Mumma podcast, sponsored by Bugaboo.
Just while we have you here, I want to bring us forward to the pushing stage of labour. When a woman is assessed and they are fully, usually, correct me if I'm wrong, the recommendation is to begin pushing, right?
I was going to say, great, you're fully dilated.
Midwives might say follow, especially if she hasn't had the epidural, some midwives might say, okay, just follow your body now. And you feel those contractions. If you feel pushy, usually when I'm with women on an epidural, it's usually either let's get going or wait a bit and then labour down a bit.
Yeah.
I guess my question is, because a lot of women don't know about the time limits placed on them during the pushing stage. And it's so important for them to know, because I don't know about you, but when I'm with a first-time mum, especially if they've had an epidural, they've lost all of that sensation. The first half an hour is getting used to what the F this pushing thing is. And I know in my head, I'm like, she starts off like this, and then I'm thinking, oh my gosh, like this, I'm watching the clock, and all of that time's kind of eaten up because she has no idea. She's never done this before. And then before you know it, an hour later, they're saying, well, we need to get the doctors on standby. And it's just because there's time limit. Now, when I'm there, I always push back and I help to facilitate a conversation. Baby's fine. Mum wants to give this a go. And somehow when I'm there, she ends up pushing it out. But usually it takes another, couple of hours. If I wasn't there, that would have been a forceps or a vacuum delivery. So I just want to hear more about how long roughly are these time limits? Why are they there? And aren't hospitals seeing that this is a really terrible thing because they're causing so many unnecessary interventions, and they even intervene when the baby and the mother are fine, which I find so confusing and frightening, actually, that they're happy to cut a large episiotomy and forceps a baby out over waiting. I just do not understand this. Could you help me understand, at least?
There's no rationale. There's actually no... Well, they would say that there is a reason. But, and it all comes back to the division of labour and birth into stages. And how they define the second stage, so this pushing phase, is usually, if you look at a textbook or medical textbook, is from full dilation to having a baby. That's how the second stage is diagnosed. And if you're pushing as a first-time mum for longer than 2 hours, they'll often say, right, it's been 2 hours without a baby. Now we are going to act and give an episiotomy or a vacuum or a forceps. And it depends. I've been in births where the midwife and the doctors are sort of like, well, no, there's progress. We can see the baby is coming. We can let go of this arbitrary 1 to 2 hour time frame. We can let go of that. Sometimes there is sense. They'll say, well, it's clear the baby's coming down and the heart rate is all okay. There's no drama here. We can afford to wait. But there might be clinicians who are less comfortable with waiting who will end up expediting the birth. Now, the issue is that we do too many vaginal examinations. So the minute the woman's fully dilated, we think, right, she's entered second stage, the clock has begun. Whereas if we properly diagnose second stage, so the baby's not ready to be born at 10 centimeters dilated. That's one piece of the puzzle that needs to happen in order for a baby to be born, full dilation. But the rest is that the baby actually needs to be in a position to come low into the pelvis, and the uterus has to change its behavior. So while you're dilating, your uterus is doing one thing. It's pulling your cervix up and out of the way. But when you enter into the pushing phase of your birth, your uterus is no longer pulling your cervix out of the way. It's pushing down from the top. You get a hormonal shift and your body goes, right, we're no longer pulling up. We're now pushing down. So there is no reason to start pushing when you're fully dilated. The time to start pushing is when your body says, right, we are ready to start pushing. And that means your baby's moved down far enough in your pelvis to trigger your beautiful birth reflexes.
But is this not known?
Unfortunately, no. I think people know about involuntary pushing and the reflex. They recognize that it happens, but there's such a focus on what we call coached pushing. And if you fully medicalize birth, you start to believe that you as the clinician are a very important part of how this goes, because the woman is in a dangerous medical scenario. And therefore you must be there to control the scenario. So part of that is measuring, surveilling, checking everything. Go, okay, you're fully dilated. That means you've entered second stage, but they've neglected to recognize that there are so many other elements to second stage. The baby has to be low in the pelvis. It has to have navigated the pelvis. The uterus has to have done the adequate hormonal shift to now be pushing down instead of pulling up. And then the woman will get an urge and a reflex to push her baby out. That's the sign that you might be entering into second stage.
But those with an epidural though, because isn't that...
So again, you're in a medical situation with an epidural. Now, physiology can't be relied upon. We're not in a physiological situation. Your clinician will and should give you some coaching about how to push your baby out. You're not going to feel all of the things that you would normally...
What would happen if a woman's on an epidural and you just wait? Would the body naturally then just expel the baby?
The body would most definitely push the baby down if it was functioning properly. So if the uterine muscle was still functioning adequately, there is some research about waiting for full dilation and then waiting for what we call passive descent, which is what you mean by laboring down. So passive descent means it acknowledges that the uterus is capable of pushing the baby down without the involvement of the woman.
When I've been with my clients and she's, they've given her 1 to 2 hours, always the pushing stage is much smoother.
Yes. So if you can allow the baby to do what we call passive descent, which means fully dilated, and now the baby's in a position where it can rotate and come down into the woman's pelvis, then of course it's going to be a shorter second stage, a shorter pushing phase, because the baby's already started the journey. And so you increase the chance of the woman being able to push her own baby out with an epidural by waiting for the passive descent. Yeah.
Well, that was a incredibly informative session. I love that. Nice and concise and Just anyone who DMs me about VEs or pushing, I'm just going to go, oh, so good. Thank you. You are a hoot. So much information in your head. I love it. If people are listening and they're like, we want a bit more of this woman, what services are you offering at the moment? And tell us about your fabulous new online course.
Oh, yes. Well, the best place to go if you want most of what I offer is the Great Birth Rebellion podcast and my social media at Melanie the Midwife. Honestly, I really want to give as much away for free as I possibly can to women. And all of my other resources and offerings and services are at melaniethemidwife.com. I am in the process of writing a book, which, of course, all of that will come out onto the website and the podcast as well. But I would just encourage women and listeners to follow along on those two things. Social media at Melanie the Midwife and the Great Birth Rebellion. And please enjoy and indulge in the Great Birth Rebellion podcast. The podcast episode is so heavily evidence-based, that I've also created every single episode has a resource page, which means it's got all the research that I use for every single episode. And so that gets sent out every week. Getting on the mailing list for the podcast at melaniethemidwife.com is kind of the way to stay the most connected with all the work. And then you'll know everything that I'm up to.
Wow. Well, congratulations. Look forward to just keep watching you from afar. And thank you for your time, Melanie.
Thanks for having me.